Okay. All right. Everybody ready to go?
Sounds good.
Awesome. Now I just start. Welcome, everyone.
Yeah. Just gonna say, welcome everyone. We'll give it just another few minutes for people to join from the waiting room, and then we'll get started. Hi everyone, welcome to the webinar. We're very excited to have you all here today to discuss the future of the patient experience. This is being hosted as a partnership between the Texas Medical Center and our BioBridge partners from the UK and Denmark. Before we turn it over to the panelists and experts to really hear from them, I wanted to give you a little bit of background both on TMC, from those of you who might not know much about us, as well as just a very sort of high-level overview of the different healthcare systems between the US, Denmark, and the UK, just to sort of help set the stage of sort of where each person and group might be coming from when we discuss this item. So from the Texas Medical Center, we're the world's largest medical center. We have over 60 plus leading institutions in clinical care and research, from the largest children's hospital at Texas Children's Hospital to the #1 cancer hospital in the country as well with MD Anderson. So it really is a great place for people to come. We see over 10 million patients a year and have over $2 billion in research funding. One of the other unique aspects that we do is actually doing a lot in innovation. And so through the TMC, we have a TMCX accelerator, which is a life science accelerator really focusing in digital health and medical devices. And this brings startup companies from around the world and across the US, of course. About a third of the people are from across the country, across the world, and about 2/3 are US companies that come in and really get to experience a boot camp and then work with our leading institutions as well on projects. So I'm sure some of you are asking, what is a BioBridge? A BioBridge is really a collaboration in life science. So it's a partnership between TMC and other countries. It actually started with Australia, then we went to the United Kingdom, and then Denmark as well. So we really focus on two sort of key areas: innovation, commercialization, really looking at digital, telehealth, medical devices, and then research and education. How can we sort of spearhead the latest in clinical research, precision medicine? And so this is part of this, when we think of lessons learned, especially coming out of the year we've all had with the pandemic, we thought, a webinar series really looking at different topics, the future of, and sort of getting to hear from experts across the world and what they're looking at. Very quick intro, just to give people a little bit of background. Denmark is universal coverage and care. They have it decentralized within regions and municipalities, but otherwise it is completely through Denmark and their healthcare system. Their healthcare is digital. They have electronic health records that really go back from when you're born all the way through. So you've got a really nice longitudinal study as well of a patient's full healthcare and delivery. 98% of Danes go through their general practitioner, much like the US and also in the UK, who then refer to sort of specialists as needed. Talking about the United Kingdom next, also very similar to Denmark in that it does have universal care through the National Health Service, NHS. And so you are automatically entitled to the free public health About 12% of United Kingdom people do have private voluntary insurance as well, sort of as a supplemental piece, but they're still very much going through that. Like Denmark, the NHS assigns one number to everyone, and you're registered as a patient with that sort of unique identifier, and your general practice information is also digital as well online. The United States is a bit different, as you all know. We're a little bit more of a hybrid model, a mix of both public and private funding. Public insurance being Medicaid and Medicare and CHIP are sort of the largest ones, but most people fall under their employer-sponsored insurance, or they buy their own through the market. And so that's very much the dominant coverage. The US has moved to electronic health records. However, it really is still done on a system by system basis. And so if you do go see people in different areas, you're not always getting that full coverage and access. We just wanted to share a little bit of that background. Since we're talking about the patient experience, a lot of that is how the health system keeps track of you, connects with you, communicates with you. And so that can bring up some different views as well, just with how the systems are garnered. So with that, thank you all for joining. I'm going to turn it back over to my colleague, Emily, who will kick off this specific panel. So thank you, everyone. Emily, I think you're on mute.
Thank you very much, Ashley. Welcome again, everyone. We're delighted to have this panel to share their experiences with you about what they're seeing in the future. I'm going to briefly introduce our panelists and then turn it over to our moderator for today. So one of our panelists is Thomas Franzen. He's the Chief Medical Project Officer at Copenhagen Children's Hospital, joining us from Copenhagen today. We also are delighted to have Katie Glinda Daggett, the Director of Patient and Family Services at Texas Children's Hospital, as well as David McNally, the Head of Experience and Care at NHS England, Sarah Christensen, the Director of Patient Education at MD Anderson Cancer Center here in the TMC, and last but not least, Adnan Iqbal, CEO and founder of Luma Health. Luma Health is a patient engagement experience platform that we have worked with here through our TMC Accelerator. So Adnan, I'm going to turn it over to you to introduce the view of patient experience and to kick off our conversation today.
Awesome, thank you. Well, huge thanks to Ashley and Emily for hosting this all-star panel. Really excited to spend time with all of our fantastic thought leaders and subject matter experts from across the world. So I know it's good morning, good evening, good afternoon, depending on where you are, but really excited to spend the next hour or so together in terms of a very rich discussion. I think patient experience has, of course, it's not a new concept, right? I mean, patient experience has been top of mind from the earliest days of healthcare. I mean, if we think about healthcare very early on, the doctor quite literally came to your house, right? That was the patient experience where doctors made house calls, and in a weird way, we're now seeing that versions of that come back, right? And so we've gone through a lot of different transitions, from physicians coming to your house to us, of course, creating large centralized health systems. And of course, now with more digital capabilities available, a real focus on access and reach, versions of the physician or your care team coming into your home in some shape, way, and form. And so really, I wanted to first open with a set of questions for the panel here. It's patient experience can mean a variety of different things, right? It's a very broad category. It at times has been viewed as a bunch of warm and fuzzies, but really it's evolved and matured, and all of you now are playing critical roles in driving patient experience for your organizations. Really, I think it'd be helpful for all of us to hear, given the different hats and different roles and different responsibilities you have, what does patient experience mean for you, right? In the health systems that we partner with here across the United States, depending on what your role is and what your vantage point is, patient experience could mean the experience from when a patient arrives in the physical building, how they interact with staff, how they interact with the care team, the physician's bedside manner, et cetera. For others, when they hear the word patient experience, it's digital, right? Others, when they hear patient experience, it's more about how do we educate people? How do we think about being involved in a patient's life, not just when they're in our physical building or we're interacting with them virtually, but when they're in their homes, right? And we think about total patient wellness. So a very, very broad category, and would love to hear, and maybe we kick off with Dr. Franzen. What does patient experience mean for you, and how do you think about it in your current role?
Thank you. Dr. Iqbal. Yeah, so the focus of our patient experience and the way we understand the patient experience until now is basically the classical understanding with a huge emphasis on the health outcomes and the patient role. And actually, this is what we are working a lot with at the moment to try to shift this emphasis from this patient view to a more holistic view, where we work with both the patient and what else is outside of this patient, but still the same human being, and the family. We've just I just briefly will show you. Maybe I will, or maybe I won't, because I'm not sharing anything.
No, we see it.
That's good.
Okay, that's good. So we have classically, and as a medical doctor myself, our patient experience view has been from the health point of view in terms of the patient, and now we're moving more holistically to approach where we see both the patient, the human being or the person, and the family. So in the patient area, we work with the health outcomes. In the person area, we work with the quality of life. In the family area, we work with coherence, or whatever your definition of family might be.
Very helpful. I think it'd be also interesting to hear how the Texas Children's Hospital's experiences. So Katie, I mean, you and Dr. Franzen treat pediatric patient populations, which of course involves the patient, the person, the family, the community. What does patient experience mean for you, and how are you guys thinking about it at Texas Children?
Yeah. Much like Dr. Franzen, we've had the traditional sort of concept of patient experience around what happens previously within our walls and now within our virtual walls as well. I think what's happening for us is it's evolving to the full journey. So the moment a family Googles us or does a search for us, to scheduling that appointment, whether it's on the phone or digitally, through their encounter and experience, and then into post-discharge. It continues to evolve though. Like, this is definitely not an overnight transition. Our number one focus is truly around providing safe and high quality care. Hands down, nothing is a good experience without that. But beyond that, we've really worked to hone in on being personalized, which is not always easy in large scale health systems like ours. And then also being compassionate. Of course, that's got to be at the core of everything we do, both for our patients and the entire family. And family is a very broad definition. So whomever that family is, as determined by the patient and primary guardians, then that's the family that we are most concerned with partnering with and ensuring they have a great experience.
Thank you. David, I'll turn to you. I mean, you have with NHS a very broad mandate, right? It's the entire UK population. It's primary care, it's specialty care, it's all different ages, shapes, sizes, fields of people. What does patient experience mean for you, and how are you thinking about it here in the immediate term?
Thanks, Adam. I build on what Thomas said to start with, but I think that there's something really important about that shift that we're making to patients being partners in their own care, and making that real. We clearly have, it's like a lot of these things, we've done some of it, but we really don't do it consistently enough. And I think that's if we want to get people's experience right, I think we need to absolutely put them at the center of it in that sense. I think the other key element for us, I think, is that really just starting with what matters to people. Because I think it's so often the case that if we ask patients, and you'll have all experienced this, if we ask patients, they tell us what matters to them is different to what we thought would matter to them. And the classic examples are often around waiting times, that we come up with all sorts of very clever ways in which we think things we might do when people are waiting. And actually what people tell us is all we really want to know is how long we're going to have to wait for. And if you tell us that, that's fine. So that simple communication, that provision of information. But actually you ask clinicians what needs to be addressed in terms of waiting times, they'll never think of that. It'll always be something much more complicated. So just asking those questions, I think, gets us often to the heart of what we need to get to much more quickly than a lot of other things that we consider.
Awesome. Thank you. And Sarah, I'll ask you the same question. I mean, of course, you have you engage with a patient in a scenario that can be quite stressful, right? We always talk about needing to see a doctor is hard, but actually seeing a doctor should be easy. And unfortunately, it's not for a lot of people. The oncology setting, of course, is it's not your everyday routine care, and so there's added stress and anxiety, I'm sure, that a person and their family experience. And so, how do you think about patient experience, and what are you immediately focused on?
Absolutely. So I echo what the other panelists said. We really look at patients as our partner in the care. And how do we have that open communication from accessing us to get that appointment to come in to be seen, all the way through the continuum of care. We really try to connect at every point, and we look at our patients as co-designers in many of our processes and systems. So we'll ask them, you know, again, with the examples like, well, we think we know what's best. For example, COVID screening, we are able to send a text message every time prior to an appointment. And we thought, well, radiation patients, they're coming every day. They don't want a text every day from us. So we asked them, they said, absolutely, I want that text because then I'm prepared. I've got my pass and I can come right in. So just always, again, asking the patient, what's important to you, what system works best for you, and partnering with them really as co-designers.
Excellent. So I think we've teased out some really meaty themes here that we can dive into further here. But we of course have heard the theme of that all of you have shared is moving from a patient view in terms of direct interaction to a more holistic view of the patient in terms of where they're in their home, their family, their community, and all the different touch points around them. We've heard the theme about more and more virtual, more and more digital, right? More and more text first type communication. And then we've also heard the theme around the full patient journey, right? From even before a patient's a patient, when they're a person and potentially searching for care, to how they access that care, to how they navigate that care. I like the phrase co-designers and partners in care. And then of course, at the end of the day, what is a must-have is the core product, right? Which is safe and high quality care. And so with all of that in mind, you know, I think one thing I'll share is from a partner of health systems, you know, across the country and across the world, the evolution we've seen from a patient engagement standpoint, which again is often viewed as a subset of patient experience and has been fairly loosely defined. And I think for the longest time just meant, hey, we have to get a hold of people and that's engagement. But really we've seen and been fortunate to help create and lead this category, but patient engagement over the past 5 years has really evolved. And I'm curious to know how you think about patient engagement and experience evolving in the next 5 years, but we've seen it go from essentially patient engagement in 2019 meant modern messaging, right? Where it was, hey, we can't just robocall people and hope they can find us and navigate care, but we need text first, intelligent, modern messaging that is integrated also with some underlying system of truth, right? Most often the electronic health record. It's kind of table stakes now. And really what we saw in late 2019 and early 2020, even pre-pandemic, was a shift from folks saying, okay, messaging is important, it's a must-have, but I need to be able to stitch together a set of solutions. I can't operate in a world where I have 6, 8, 10 different point solutions and band-aids that are solving specific pain points along that patient journey. And so looking to have messaging plus scheduling plus telehealth plus referral management, right? More of a holistic set of coordinated touch points with the patient. And then really what we have always seen as a North Star and where we now see healthcare really evolving too rapidly is patient relationship, right? Patient engagement really means patient relationship. And that's the words and the phrases we hear are harmonized patient experience, stitched together end-to-end patient journey. And what we're seeing there, what that means is, and this has of course been accelerated by the pandemic, which forced everyone to engage virtually and to rethink, you know, how they deliver care and how people access care. But it's really that view of, okay, I need to have a single partner to drive that end-to-end journey. My electronic health record is my clinical source of truth. It is my clinical decision support tool and my billing tool, right? I'll have some marketing and patient as a customer type tools, be it our CRM like Salesforce. But what I need is a patient conversational journey of record that can really help a patient navigate that end-to-end journey and help us as the health system be a part of that patient success equation. So those are some observations we've seen over the past handful of years. As we look to the next 5 years, how do you see the patient experience and patient engagement space really evolving? And you talked about your immediate term priorities and efforts, but where do you see real change happening that'll be dramatic and really impactful for patients? And so maybe we start with Sarah, because you had started on that track, and then we can ask folks to chime in and share their thoughts.
Sure. No, it's really going to be interesting to see what happens in the next 5 years. As you mentioned, with COVID, we all had to shift how we deliver services, and we became very versed in how to provide virtual care. At MD Anderson, we had not done many video visits prior to April 2020. Since that time, we've done over 200,000 video visits with patients. So rapid escalation and also rapid adoption by patients. I think the thing to be aware of, as technology improves, we don't want to lose that human touch. We want to be sure that there's always that connection, and how do we remain responsive as technology becomes more and more readily available, but also how do we meet the needs of patients that might not have the same access as others when we rely so heavily on things like a patient portal. So I think it will be interesting to see how it all evolves and develops in tandem.
Excellent. Other panelists who want to share their point of view in terms of what do the next 5 years look like and what are really going to be the dramatic shifts? Yeah, Dr. Franzen.
Yeah, thank you. Yeah, so I completely agree with the focus described here. And I think one of the shifts that will happen, and we're seeing at the moment, and I'm sure you're seeing it at the other places as well, is more and more home treatment and emphasis then when you're not at home. You come in and the quality of the visit is more and more important, and the relationship and the safety will increase in importance once you are at the hospital, and the feeling of safety when you are at home being treated. I think compared to some of the US hospitals, when because of the universal healthcare system, patients don't choose us. They have to come here because that's the choice. And I think that makes that initial journey a little bit different. But once they're here, I think the shift to home treatment. So once they are here at the hospital, we need to provide some sort of home because they are really ill when they're here. But we will have more and more focus on our actual job to get them back to home.
Other folks have a point of view they want to share. Yeah, Katie.
Yeah, I would say, it's really been interesting to Sarah's point. Wow, did the pandemic accelerate evolution? It really pushed healthcare, I think, out of its comfort zone and really quickly. And so some of the things that, at least as a pediatric institution, we had hemmed and hawed about, do we really move forward with this? How do we do this? We very quickly had to get over that and figure it out and go. And that's what we did. And with that, our families have given us incredible feedback. It's been very worthwhile. We've gotten, as Sarah said, when you ask your families what they want, they always surprise you. You may, even if you yourself are a patient, when you really talk to your stakeholders, they have feedback that surprises you. And so they very much, families were partners in helping to launch our digital health program. And we continue to lean on them for feedback. We are integrated with our EMR or EHR, and it's clunky at times, and we're working through that because we know this is a win for families. It's a win for providers to be able to have virtual visits when possible. We talk a lot with our surgical patients. When you have that general follow-up and really you're not having any problems, everything's healing well, you're on your way to recovery. How important is it, say in Texas, to drive 2.5 hours into a very busy metropolitan area, the medical center, and then have a 15-minute encounter and then go home? when really, if everything's going well, we can talk through that digitally, virtually. So that's been a tremendous win. We also are very aware of the equity concerns. Even from the simplicity of some of our more rural parts of Texas and the country don't have strong internet. They don't have strong Wi-Fi. So to have a constant video connection is just not a possibility. And then the other piece is that, again, we're working with our families on this, but every health platform is a little different. So just because I access my adult care provider through one platform, when I want to access my child's provider, it's a totally different platform. So there's a lot of learning that has to happen. And my hope is in the next 5 years, that will really come together and become a much simpler solution, so that from the consumer side, from the patient side, they're not having to figure all this out. That we as the providers have come together to make it simple to access care no matter where you're going.
Awesome. You mentioned you asked patients questions and then you're surprised. What have been some of the learnings and insights that have been the most surprising?
Well, so a lot of them during this virtual time, this sounds so silly now, but in the very beginning of the pandemic, we quickly stood up a virtual family focus group, which, oh my gosh, they were so committed. They met with us like twice a week. And so at first we said, gosh, how do you feel about coming into the hospital? Do you want to, are you okay with a digital visit? And of course, there was a resounding yes, yes, yes. Why do I have to come in at all? Thank you for bringing this along. That's been really tremendous. But one of the things that's also been interesting is as the United States and Houston in particular has moved through this pandemic, our assumption was that everyone would stay very focused on that digital space and always wanting the telehealth or e-health virtual visit. And that's not been the situation. Many of our families, they still want to come in and have that face-to-face, human-to-human touch point. And then they're okay going back to that telehealth space. But it's important, again, I think Sarah mentioned this, you've got to continue to have that the human touch and the human experience to uphold the digital experience.
Awesome. And just to follow up here, and David, I'm gonna get to you most certainly. One of our panelists, one of our participants asked a follow-up question, Katie, which is you're capturing, well, how do you go about capturing rich feedback from patients? And then how do you turn that into actionable insights? And so you give an example of virtual health, but how are you guys doing that? Because I'm sure you're getting lots of data, and then how do you translate that to real impact?
Yeah, we're very fortunate that we have a very robust survey program. So we work with a vendor who that is their specialty is patient experience surveying, and we have very early on, because our stakeholders, when you think about parents and guardians of young children, they typically might maybe skew a little younger than your average age in your adult population care facility. So we had to switch to text messaging for surveys and email very early on, I would say several years ago. And that's really increased our ability to capture the voice of those families from just very the quality controls and truly moving through their experience. So that's one set of data. We also have focus groups and virtual family advisory committees. That's really important as well. The discussion, hearing, again, not just the data point, but the story behind it, why families feel the way they do, what they're really facing, the bigger story. So we're able to marry both the data points from the surveys as well as that qualitative data and come forward with a very full picture of what is happening. So we're able to look at trends across the whole system and then identify qualitative trends and figure out where they meet. From there, then we're able to pull apart our pain points. For example, we've launched recently a way to digitally check in when you arrive for your appointment. This is great. There's less touch, less interaction in the COVID world. This is important. But through that and through the survey points and the feedback we got from families, we recognized that there was still some discomfort with strictly relying on a digital check-in. There was still a need for a person, a sort of a floater, if you will, to assist with checking in questions. Am I lost? So, some of that those kind of evolutionary changes in how we deliver service and care, we find that the data points from the surveys plus the stories that our families share with us really help us understand how to make improvements and do so rapidly.
Awesome, thank you, David. I definitely want to hear from you on how you see patient experience evolving in the next 5 years and where you see the greatest area of impact. I think what will also be super helpful for all of us to benefit from your perspective on it. We've heard this theme now of telehealth or virtual care equity, right? And I think all of our organizations have implemented telehealth or virtual care in some shape, point, form. Across the country, we've seen in the United States, health systems, delivery systems go from having 2 to 3% of the providers on virtual care capabilities to having 80% plus of their provider base or even higher on virtual care capabilities. So we've done this experiment now for 14 months, but we've seen that that's in the pandemic, because I think across the world really laid bare that there are access challenges, there are equity, there's healthcare inequity, right, based on socioeconomic status, race, ethnicity, where you live, what have you. And we've seen that especially be true for telehealth, right? And I'm curious to get your perspective on, of course, the longer term 5-year outlook, but also given the broad mandate you have with the NHS, like how are you really solving for equity, especially when it comes to more of the digital tools that you may already be using and employing?
It's a very good question, and I think some of the answer has to lie in what colleagues have already been talking about. So I think what Katie, you were talking about how you have to give people those options in their pathways is something that we learned very early on, and we did some surveys of clinicians across England almost a year ago, actually, back in June of last year. And the clinicians were yes digital, yes yes remote, and so on and so forth. The minute we asked the patients for their view on it, they fundamentally agreed, but put all those cautions in about there are situations in which either we personally, for our particular context, would need that direct contact in the way that Katie talked about. But interestingly, just given the material reality of that digital poverty in some cases, then actually that just is the only way for some people that would be possible at a given moment, because we can't solve the connectivity issue from the healthcare side. That's clearly a wider social issue that absolutely needs addressing, and having proper Wi-Fi, even having access to the right kind of equipment, is something I think as societies we are going to have to face. For those communities where that is an issue, clearly we can't solve that, but I think that has to be a real option for people over the coming years. I think there's one aspect of it which I think is going to be really interesting for us in the next few years, which is the learning from when does this work and when doesn't it, from a clinical point of view. Because I think we've still got so far to go. As we've said, we've only been doing this for 14 months, and there's a lot of risk attached to it if you think about it from a clinic. I'm not even a clinician, but it's obvious that from a clinical point of view, there's a lot of risk attached to it. And I think as working that through in different specialties is going to be really, really important. Just understanding when it's not quite the right thing to do, and we'll continue to learn that, I think, over the next few years. Last thing I was going to say at this point was just building on one of Sarah's points really about co-design. I do think that the pandemic has just given us some opportunities around co-design, because it's easier, because we can do it remotely with people. And the great example for us, I think, has been in musculoskeletal services and thinking about how we recover those services. We've been able to bring patients into those conversations to co-design that, who can't get out of the house. They literally can't get out of the house for all sorts of obvious reasons around those sorts of conditions. But we've been able, and they've never been able to be involved in those conversations before, but we've been able to do that for the first time. So there are lots of opportunities around co-design as well, I think.
Excellent. I want to focus on the digital track here, and then we can level up and expand again. But we've heard this, the common theme here that patients are pulling for and craving more digital touch points. Our organizations either have willingly accepted that challenge or been forced into accept that challenge, right? In terms of leveraging text-first communication, video, virtual visits, potential automating conversations or routine engagement through chatbots, employing patient portals that are easier to use, what have you. Given we have now at least a few quarters of data in your different organizations, how is this in line and impacting patients' experience in terms of their expectations? And then from your staff's perspective, right, which are in the provider perspective, that are an incredibly important part of that patient success equation, where are we meeting expectations today, and where are there still gaps? And David, since I think you had started that theme, if you want to start there with your thoughts, would be super helpful.
I mean, I think this stage the indications are very positive, actually. I mean, most of our surveys run annually, and some of the national surveys that we run annually or biannually. So we're not quite there yet in having that evidence through this period. But the kind of surveys that we have got access to are showing at this point that that people are very positive, actually. And I mean, it's the level of understanding that people have in the pandemic, I think, as much as anything, that the challenges around waiting times for more routine activity. Even people are very patient about that in terms of their responses. But yeah, I mean, all the evidence we've seen so far is that the people are very. It certainly hasn't made anything worse for people in terms of how people report an experience, and in some aspects better, I think. So yeah, it's good so far, so good.
Excellent. Dr. Franzen, I would be curious to get your thoughts. You touched upon home care. You made a very, I think, interesting and clear point, is that your patients don't often have the luxury of choice, right? So what are the early feedback you're seeing in terms of, is this in line with your patient's experience? Is it in line with their demanding? And then from your organization standpoint, are your internal care team providers and staff satisfied with this shift to more and more digital?
Certainly, I think the experience is very similar to what told by the NHS, and the users are certainly happy. I think we are seeing a lot better filtering of the visits, as Katie was saying, that when you don't need to come into the hospital, you don't want to. You don't want to come for a 15-minute visit just to find out that everything is fine, because you already knew that. But when you have issues, you want to come. And it also provided us the opportunity to spend more time on the more vulnerable families, because a lot of the time spent with families that are doing fine can now be used for the more vulnerable families, and actually providing some more equality in patient care. So in terms of digitalization and individualization, I think this has been a fantastic opportunity, and we don't see families being less satisfied. On the contrary.
Sarah, your thoughts on the same question?
Sure. I think with the shift to virtual, we've been able to really identify patient preference. Do they want to be getting a text message versus a phone call versus an email? And having electronic health record, we're able to capture that and then always provide them with that service when they, once they indicate their preference. An interesting thing, we at MD Anderson, we have patient libraries, and with COVID, we've had to shut them down. And our librarians and health educators are really missing that patient contact. And they had no strong way for patients to work with them besides a basic email address. So we were able to add a chat functionality to our library homepage. We were able to add a texting resource as well. And then within our health system, we added a Ask the Librarian default for when patients had any sort of health related question, not about their care, but about more information. So just looking at different creative avenues to reach patients and for patients to reach us, I think it helped address that immediacy of needs. When you're not face to face, if you can text someone or email them, you should be getting a response same day, sometimes right away, or in a short time frame, versus sometimes with an email or a call might take longer. So just it met a lot of needs on staff satisfaction. Like I'm reaching patients again, I'm working with them, and we tried to find at least several different methods where patients could reach us based on the technology they might have.
Excellent. Katie, anything you wanted to add?
I think the last thing that I might add is that the virtual space has allowed us to be much more nimble in how we connect with our families. So just yesterday, in the Houston area, we had what we call, in quotes, a rain event. Houston's had extensive flooding, often in May, and we get very nervous when there is a prediction of heavy rains and potential flooding. And so typically, 2 years ago, had this occurred, we would have canceled all of our outpatient clinic appointments. So we would have said, nope, everyone stay home. We want you to be safe. We want our staff to be safe. However, we were able to convert those to digital visits, virtual visits. And so that allowed our providers to remain safe, our families to remain safe, and then to still have that encounter and that check-in. Certainly there was a handful that we've rescheduled for next week or the week after, but to be able to continue care with a disruption like that was a real win for everyone. And that's completely because of this wonderful digital space that we're in now.
Excellent. One thing that we're seeing is and Dr. Franzen, you're very much open with this, is this shift to home care, right? And thinking about total patient wellness. And of course, it's, step one of it was really, we have to ensure access, right? Because if we don't ensure access, then the person is a person and they're not yet a patient. We've seen this shift, of course, then also to be more and more digital, right? How can we be in your lives and in your homes and help you on your care journey? And of course, we now have those tools. And as you have all indicated, there's clear pull, right, from patients, their families. There's the satisfaction rates there are through the roof compared to what people used to experience, which is drive 2.5 hours for a 15-minute visit and then drive back. And then obviously it's not just 15-minute visit, because there's that an hour of parking and checking in and kiosking and all those things. And so what we're seeing is across the health systems we partner with is this real desire to be involved in the patient's lives in between and after visits, right? And I'll share a very I think interesting and novel example, but would love to see how elements of this are also part of your approach today, or will be part of your approach here in the near future. We work with often endocrinologists who treat chronic care, treat diabetes, right? And we're seeing some of our clinics and health systems, the minute a patient's diagnosed with diabetes, they're doing all the right things, right? They have them in an automated set of messaging that sends the patient content around importance of their wellness, of exercising, their diet, etc. So there's all this rich content going to the patient, text first, in the patient's preferred language, right? Not having to log into a clunky app or portal, what have you. So that's good. But the other more interesting thing they're doing is they're automatically scheduling a visit 1 month after diagnosis with one of their nutritionists. And this is 100% virtual visit. And the nutritionist, there's a set of communication that goes to the patient beforehand, making sure that they have their camera on their phone enabled and the voice is enabled and all those things. But the nutritionist simply asks the patient to take them through a tour of their kitchen and their pantry, right? And so they ask them to open the fridge and you see, cans of Diet Coke or a pantry full of potato chips, right? And so what we found that is you can do all the right things as a care team in terms of ensuring access, getting the patient the right content, guiding them, even of course delivering the product, i.e. making the right clinical decisions, making the right therapeutic interventions. And a patient similarly can be very compliant and take their medicines and do all the right things. But if they aren't having that meaningful behavioral change or change in diet, change in just how they live, it doesn't really matter how great you are in terms of one, enabling access, and two, delivering great therapeutic decisions, right? In terms of that goal, which I think all of you open with, which is health outcome, right? This is a way to have that window into that patient as a person, not just as a patient when they're sitting in front of you, right? And you have they're of course on their best behavior. I'm guilty of that myself, right? When you're in the doctor's office, you're on your best behavior. And so I shared a very real example we're seeing in terms of how health systems are leveraging technology, but also a shift in their view and approach of thinking about total patient wellness and being in the home in some shape, way, and form, whether it's directly or virtually. Are there similar examples that you all are employing today or are working on that are in line with that broader desire to be a part of a person's life, not just when they're actually seeking care, but when they're consuming care, which is all the time? And I'll let anyone raise their hand and chime in who has a meeting example. Dr. Franzen, yeah.
Yeah, so I think that's an extremely good example that you're mentioning here. And the fact that we now have this digital opportunity has actually increased the possibility for us to, for instance, say, make visits, house visits. Usually we had limitations due to distances. Even in little Denmark, we can have that issue. But now we can make a house visit, for, let's say, within 48 hours after sending your pediatric hematology patient home. You can make a house visit, see how will this work in your home. Let's see, how is your bathroom looking? Where can you have the different tools for the catheter? Where can you have your food? How can you prepare it? And vice versa, we see that one of the issues that the patients or kids in a hospital have is being able to follow the friends, being able to follow school. All of a sudden, they had equal opportunity for school. They had equal opportunity for spending time with their friends. And I think that has been an eye-opener. And in the future, I'm sure this will give opportunities for the kids while at the hospital to follow home life, which will make it equally much more easy to come back to life after a long stay at the hospital or a long time of disease.
Excellent, thank you. Other insights from the panelists? Yeah, Sarah.
So yes, we have a really interesting pilot being developed right now at Anderson. And we spoke with our Patient Family Advisory Council and said, what do you think about this concept of MD Anderson at home? Like, when we're talking about house calls, I love that. My father was a large animal vet, and so I used to go with him all the time to the farms, and the power of a house call. So we asked our patients, when would it be most beneficial? And really, after surgery, after you've been discharged from the hospital, or maybe during chemotherapy treatment, when you're having some symptoms or symptom management. So we're looking at this plan to how do we provide remote monitoring? So not just a video visit, but can we get daily information? Can we send you a short survey? How are you feeling? Is there a change? And can you report? And if there's some minor concern, maybe we push you an educational document. Oh, here's some ideas to relieve maybe some of your symptoms. If it's more moderate, there would be a flag. So it would be followed up with an immediate call from a nurse or from a care provider saying, hey, I see you flagged this as a concern. Let's talk about it, and then determine if you need to come in and be seen or not. And then also looking at taking that one step further into biometrics. Can we provide them with a thermometer, a scale, a blood pressure cuff, so they can gather more data, send that to us, and it provides a larger picture of how they're doing at home. And even to the point where, can we provide them with an iPad or some sort of device and a network plan, so they always are able to contact us with that information. So we're exploring this in a couple different ways, and it's very exciting to see what will come of this, and the comfort level patients have of, they're always feeling connected, even though they're still in the comfort of their home.
Excellent. I'm going to shift gears here slightly. I think we started to touch upon it, but I wanted to spend a little more time on the actual provider and staff experience, right? We of course, the theme of our discussion today is around the patient experience, but of course our providers and our staffs are critical components of that. And I think patient experience in the past has included elements of, how do we engage a patient from a bedside manner standpoint? How do we ensure there's a welcoming and smile-filled environment for a patient as they interact with department, person to person? I'm curious, as we're going more digital, as we're employing new processes and approaches, how are your care teams, your staff finding it? Like, what is working? Where is there source of concern or stress, right? I mean, I think if we think about the electronic health record evolution, right, it was going to be amazing. It was going to digitize everything, and everything will be seamless, and it will have this amazing way to chart our patients and guide them. And of course, elements of that have been true, but it's also led to a real area of research and focus, which is provider happiness and physician burnout, and just the amount of time you're spending with the technology as opposed to with the patient. So obviously the intent of all of our digital efforts today are to make that better for patients, but I'm curious to know what the provider, staff, and care team perspective is. And David, would love your thoughts there, because I know you're doing this at scale. And maybe we start there, and then would love to benefit from the rest of the panelists' perspective on this view of an important component of the patient experience and patient success equation.
I mean, I think we've long recognized that connection, and it's intuitive and obvious, isn't it, that if we're not looking after our own care providers, then we're not going to give our patients a good experience. It's just not possible. And there's an increasing amount of evidence around that as well. And I think that the pandemic, again, has given us a context for that, hasn't it? That I know in our systems, we've had a very, very strong focus on the well-being of staff and looking after staff through the kind of pressures they have been under. And then thinking at this point in time, when we're beginning to come out of that period of the pandemic, and we're beginning to think about, in the language that we're often using, about recovery and what does that look like for our services, the recognition that what staff have been through means that they're not just going to be able to switch from doing what they've been doing in the last 14 months to stepping up, to catching up with huge backlogs overnight, and so that centrality of their well-being, I think, is something that the pandemic really has brought to the forefront in a really helpful way. I think there's just a need for us to keep doing that. I think that my worry partly is that we've had that focus because we've had the pandemic, and that we now just get obviously I'm talking from a national perspective, but that we don't just get lost in we need to get back to seeing lots and lots and lots of patients. But I think the point you're making about digital, Adam, is absolutely right. It's a great opportunity for working in different ways that allow clinicians, I think, to focus it really in the way that we've talked about already to some extent, that you can do what you can concentrate on those people who really need that most attention. And I suppose in simple terms, if you're able to do a lot of consultations remotely, then those people who might need a home visit, you've actually got the capacity to go and do it, because you've been able to shift how you manage your time in such a different way. But again, I think it's something we're so much at the beginning of, isn't it? And what we need to do is, from almost in a quality improvement kind of way, really capture the learning of all of this, and share that, because we're all on the same journey, and the next 2 or 3 years will just teach us such a lot, I think, about how we look after staff, and we take their views into account around how all of that works.
Excellent. Katie, I know you have rich data you're collecting. Are you doing that similarly from your staff and care provider side? And what are some of the interesting learnings and insights there?
We are, and particularly with our providers, our clinicians, understanding what their experience is like is just as important. So they have the expertise, they have the medical knowledge, but this is a new skill set, delivering care virtually. We actually have a wonderful training course called Breakthrough Communication that is provider to provider based. It's simulation based, and it really is a different way of communicating with the family. They go through all kinds of great scenarios, but the idea is that you're getting to that real concern that the family has, not just the little Johnny's got an earache, but oh gosh, we have a history in our family of individuals, becoming deaf at a certain age. And so it's not just an earache, it's this much bigger picture. So it's a great, great training. We've adapted that to include the digital space, because connecting with families virtually is very different. And how do you create that real engagement and that warmth? And so we've been able to tweak that curriculum to help providers feel more comfortable in the space, to give them some tools so that if they're nervous about being on camera, if they're not sure really how this is going to go, they've got some resources, and also they can phone a friend when they're when there's a problem or whatnot. The other piece is that, and when we launched all of this, we just wanted to have our visits back last summer. Since then, we know that there are technical difficulties. And so how do we support both the provider side and the patient side with that? For example, one process improvement is that we're now having one of our MAs, our medical assistants, do a lot of the triaging ahead of time, and to sort of log into that visit and say, hey, Dr. So-and-so is going to be with you in about 10 minutes. He's with another patient. I'll be here if you need me. Letting families know that we're there, because the reality is we do run late still, things happen. And so really supporting our providers in that regard so that they can focus in on the clinical care and not necessarily be worried about how they're going to have a technical fix if their patient's mic isn't working. And so those have been really important pieces, and will continue to be as we move forward.
Excellent. Sarah, you touched upon a very real example of how you plug the librarians back in, right? A really core part of the overall care delivery team. How are your staff and providers finding things that are working and things that there are still gaps and things that are less than desired?
As Katie mentioned, it's learning a new skill. It's delivering care in a whole new method, and providing tip sheets and trainings, and even as much as how to write a note, how to really capture the essence of the encounter in a new way. I think it's been very helpful resources. As we know, burnout is real. Burnout is a very tangible result of this immediate and necessary shift to all of the virtual visits. Building in a little bit of buffer time. What's interesting now is you will find back-to-back patients or back-to-back meetings because you're not walking to another building. You are just clicking a button. So at 11 and 11:01, you can be in 2 different places. And so just acknowledging what's going on, and then looking at some creative solutions to address how do we take care of ourselves and have self-care in the delivery of cancer care.
Thank you. Dr. Franzen, would love your insight as a clinician, right? You have a unique perspective, so would love to get your thoughts here.
Yeah, I have some thoughts. First of all, because being a pediatrician and as Texas Children being pediatric institutions, we've not been hit as hard in terms of sick kids, but we've been hit hard, obviously, as well as everyone else, in terms of the digital challenges. But I think what we've found both here and other places is that this has also empowered the staff in many ways, being able to find solutions without sometimes very fast, once the different levels of the pandemic have shifted in different countries. Staff have been forced to find solutions very often outside of in addition to what the administration did, and I think a lot of satisfaction has come from this, and it also has given them some new tools. And in the way we've co-created or worked with the co-creation of our patient experiences, we've worked on a user bank where needs from different users are put in the bank, and when we design different user experiences, we go to the bank to pick up the user needs. And in this bank, we also put in staff needs, and this bank has been expanded by these new challenges. So the COVID situation has really broadened our mind as to what are the needs, both of the patients, the families, and also the staff. So the bank looks different now. So this has been an eye-opener.
Excellent. I'm going to touch upon another theme that we've all articulated here, which is healthcare transformation, healthcare technology transformation. I'll share a point of view from Cook County Health, which is the second largest county in the United States, in the greater Chicago area. And their chief information officer shared with us that healthcare transformation and healthcare technology transformation in particular has really been accelerated by 5 to 7 years in the span of weeks and months. And so now kind of coming out of that rapid transformation, as your organizations, which I'm sure are also looking at financial constraints and some of just the broader pressures we think about healthcare globally, and that there's quite literally not enough dollars to pay for and meet the demand that we have today, that we'll continue to see. how do you define value when you're thinking through improving patient experience, your initiatives underway? How do you think about return on investment when implementing new solutions? And are there nuances to how you think about that in terms of ROI between, where the patient is on the journey, like pre-visit, in-visit, post-visit? Like, what are the structures you're using to evaluate improvements and initiatives you have, and with that real lens on ROI? I think folks in the audience have asked similar questions around, like, hey, all of this makes sense, but I only have so many resources, and I'm being asked to show ROI when I bring forth a proposal and want to drive real patient experience and improvement. How are you all thinking about that, and what frameworks and structures are you using? This is the brass tacks questions.
At Texas Children's, we're actually looking at data in a really different way with this, because we think we know the answers, but we need to prove that with data. We need to really have some statistical analysis around that. And so really marrying our provider and staff engagement data with our patient experience data is crucial, because it doesn't matter if a provider is seeing, twice as many patients, if then at night they're spending 3 extra hours and logging into the EHR, they're burning out, and then they leave. And so finding that balance of what is that magical metric? What is the number that really optimizes our ability to bring in meaningful revenue and have strong outcomes for both patients and staff and providers? So that's something we've just begun really looking at and trying to understand. We love big data, and so utilizing those things to help tell the story in a different way is definitely on our radar and the direction that we're going.
Thanks, Katie. Other perspectives on ROI frameworks and approaches you're using to evaluate efforts and initiatives you have underway or that are planned?
I think the example I might talk about is I mean, again, we're working at a much more strategic than policy level, but there is a lot of conversation at the moment about in terms of the co-design space. So what difference does it make if you actually work with people in that way? Now, we've talked about examples of that already on this call, and for those that work in that way, it is very obvious that what that allows us to do, and we've said it today, that it allows us to focus on what really matters to people. And it actually means that we don't waste time doing things that don't matter to people, that don't get to the heart of what's important for them. But actually the evidence base around all of that is actually quite weak at the moment. And so actually the conversation we're having is about, so if we're really advocating more of that in the work that we do. So we're just moving in England to very much an integrated care system approach, which we've been developing for quite a long time, but we're putting that on a much firmer footing in terms of legislation. And we're saying within that, we really want to push very hard on the co-production and co-design piece. But the question is coming back, how do we measure that? I can't give you that answer in a minute, but I think it's just really interesting that there's a recognition that has to be something that we get better at, actually demonstrating the value of working with patients and others in that design of the design and the redesign of our services.
Excellent.
I'll add to that.
Yeah.
I was just going to say, very similar to Texas Children's, we're looking at patient satisfaction data all the time, and where are the pain points, and really where's the largest gap, and where can we focus our attention. And what really began to bubble up to the surface is it's the time between when they schedule their appointment to the day they're seen on campus. There's a sensation of a void. From our standpoint, everything's ready to go. We know they're coming, but there's not enough or the appropriate type of communication from a patient standpoint, the reassurance that they're looking for. So then you start looking at more different robust solutions. Do you try to narrow that time so there's not so much space, or what kind of communications can you provide to give that reassurance that we know you're there, we know you're coming? And again, it's listening to the patient voice to find out where do you indeed want to focus your time and attention.
Excellent. Dr. Franzen.
Yes, thank you. So one of the luxuries we have at our institution is that Børneriget, the new children's hospital in Copenhagen, is not there yet. So we actually have the opportunity in order to measure the different ideas and co-creations that we come up with. We have the opportunity at the moment to make some baseline measures. That goes both for different registries, and also what we found is the need to develop more relevant child focused patient-reported outcome and experience measures. So both PREMS and PROMs, and specifically the PREMS for the smaller children. And so, I mean, with that, I mean children from 3 to 8, but also youth from, let's say, 13 to 17. We don't have very good PREMS, patient-reported experience measures for those. So this has given us the opportunity and the alarm that this is something we need to go and look at in order to measure what are we actually doing when we're doing all these different co-creations. Is it making a difference or is it not?
Excellent. Yeah, I think we've talked, and thank you all for sharing all the different initiatives that we've taken in achieving our patient experience goals. We've touched upon the data-driven approach to understand what's working, what's not working, where there are gaps today, where there's an opportunity for improvement. I love this dialogue here around, okay, how do we continue to assess return on investment for what we've already implemented, and how we're thinking about where we want to invest going forward. You know, I want to get to a theme that we haven't spent that much time up on yet, but it's the concept of patient choice, and the fact that all of us, whether directly or indirectly, are operating in an increasingly more competitive environment, right? Where you think about people and patients don't have to go to healthcare to get healthcare, right? You can go to Walmart, you can go to your pharmacy like a CVS or Boots. The tech companies are coming, right? You know, these are all things we're aware of. The move to digital, of course, has also underlined the fact that people, the way we interact with products and services in every other part of our life, we're now demanding the same from healthcare, especially if we're paying for more and more of it ourselves. And that of course is especially true in the United States, where all of us as patients and people are spending more and more of our own money on healthcare. We have more choice, and we no longer just choose once, we choose at every interaction. And so, you know, we often hear the feedback from our health system clients and partners where they won't say that, hey, my biggest competitor is the health system down the street, right? They'll highlight it's Walmart, it's CVS, it's Amazon, right? You know, how as you guys think about patient experience, and of course the critical product being a fantastic, safe, high quality health outcome, but if you think about packaging that and having more share of mind of your people, your patients, your patient populations, how are you thinking about that in an increasingly competitive environment where there's at least more noise, right? You can talk to a health coach on your phone, and that might be sufficient, but may also still be insufficient. So curious to know how folks are thinking about that and how that's guiding your patient experience efforts. Who wants to go first? It's a tough question, I know. Dr. Franzen.
I'll jump in. I'll start.
Okay, fine. So let's start with Sarah, and then I saw you raise your hand, Dr. Franzen. Yeah.
Anyway, okay. So I think, you know, patients make a choice for many reasons, and part of that might be reputation. So if patients are coming to us based on reputation, that's fantastic. But are they staying? And are they staying because of the quality of care? And as you said, you know, safety and outcomes are always the top priority. But is there additional factor that makes people want to stay with us? And one thing that we've done is implement a service excellence training for all employees throughout our institution. And that's looking at how do you communicate? How do you respond with empathy? How do you empower yourself and others? And just providing this quality service that permeates every element of their experience within the institution. So I think it's taking it to that next step. And again, you can listen to your stakeholders, you can get their feedback, but then can you also meet their needs and show this excellence in care, but also in service.
Dr. Franzen, I think you had raised your hand.
Yeah, yeah, that's right.
Your digital hand.
That's right. one difference for us, and I suppose it's also the same for NHS, is that we're not really in a competition, being a tertiary institution in a universal health system as we are. We are not in a competition in terms of could they go somewhere else, but obviously we are in a competition in terms of how satisfied our families and patients with coming here. And one of the focuses that we've brought up now is that in order to have a good ability to work with the patients at home, we also need to be able to partner not only with the parents, but we've shifted also being able to partner with the kids. And this creates some challenges in terms of the relation work with the kids. Obviously, we're not asking a 4-year-old to decide if they want this or that type of chemo, but we are negotiating and discussing with the kids how this could be a good experience for them. And that's a different type of partnering than the partnering that you do with the parents. And a lot of the partnering work we do in institutions is actually with the parents. We have not been very good at focusing on partnering with the kids. So that's one area of emphasis that we have. And in terms of partnering with kids, we've have a large focus on integrating play in different parts of our work. We've integrated the play into the academics, doing more research. What is actually working when you use play? We've integrated play into the building, and we are integrating the play into the treatments. So a lot of time this play integration has been based on specific people very great at doing specific things, and this ability is lost once this person leaves. Or let's say an app, once an app is developed, if the company leaves or the contract is stopped, then this function also leaves. So we've focused a lot on integrating this play into the entire culture of the place. So it's a playful approach in all of the different areas of the institution.
Excellent. We've one is this has been such a rich discussion. I'm glad it's recorded because I was taking notes, but I couldn't take notes as fast and furious as I would love to. I'm going to kind of get to my final question, but we've touched upon very broad themes. We've talked about specifics. We've shared kind of 5-year outlook, what we're measuring, how we're thinking about it, where we get excited. What I'd love for each of you to share with us is a little more personal. It's really what is one project or initiative or priority today, or that's near term for you, that you're most proud of and most excited about, right? The thing that just is giving you those happy goosebumps as you think is like, this is possible and I'm getting to drive this.
I'm happy to start.
Yeah, please, David.
It's back to the co-design work, really. I mean, it's something that we've very strongly advocated as the lead policy part of the NHS around patient experience. We've always advocated this is something we have to do with patients and not to them. But actually, in the pandemic has provided us with yet another opportunity. One of my themes today, hasn't it, really? But another opportunity where we've done a piece of work nationally, where we've looked at what are the key lessons that we've learned from the pandemic and the way we've had to change things, but not just in terms of how we deliver services, but just in terms of the way we actually plan services. And the recommendation that's come out of that, just in terms of the language we're using, is that we should be using co-production as the default way in which we plan and design our services. And that's a very different place to the place we've been in before. So we've done, and I guess this is probably true for all of us, we've had some elements of co-design, but it's not been consistent. And we're really excited by that, because it just means that we've got an opportunity across the whole of our healthcare system to really push that agenda forward and really have patients at the table, sharing what matters to them in the way that we've been talking about in other parts of this conversation. But that's a national initiative. And it's a national message that we've just not had before. And I think that'll make a huge difference to the way in which we are able to improve patient experience in the next 3 to 4 years.
Thanks, David. Katie?
Yeah, we're in the process at Texas Children's. In fact, we just broke ground on a new facility that will be in Central Texas. So that's about a 3.5-hour drive from the Houston area. And what's really unique about this is because of the disruption that we've just lived through, we're able to really think through the design with a different lens. So taking what we know from our old models and integrating these new learnings and the conveniences, the technologies, and absolutely, David, I affirm what you're saying 100%, utilizing our families and providers in helping to design not just the facility, but the processes and the way that families access care there. And so that's a really new and unique space, sort of a blank canvas. And we're really excited about what's to come and what's possible in the new world of healthcare.
Thanks, Katie. Yeah, Dr. Franzen.
Yeah, no, I was just scratching my head, but I will answer the question, because very much along the same line as Katie and David. The thing that makes me very happy at the moment is just a recent donation from the Ole Kirk's Foundation in terms of user experience team that we've been able to build 10 different competencies and 2 new test facilities for this co-production. So the anthropologists and psychologists and play designers and architects gives us this new opportunity to now test and develop this new building that we are going into, and actually now have 2 new test facilities in order to test and test and test before we actually put it into the building. And this is fantastic, both in terms of using the patients and the parents, but also using the staff and the providers.
Excellent. And Sarah, would love for you to share your thoughts here.
Sure. What I find really exciting is we're expanding the reach of our patient advisors. Rather than having a committee go to them and say, here's my concept, what do you think, once a month, we actually are embedding patients, at least 2, on institutional committees. So they are part of the committee work group. They're getting the minutes. They're part of the conversation. So we're getting much more real-time discussion and decision-making instead of holding things and getting opinion and bringing it back. So really showing that they are a valued partner in our decisions has been tremendously exciting.
Excellent. Well, I want to say thank you to each of you for the work you do, your organizations do, in terms of the impact and the service and in terms of your patients and your community. So thank you. I think the past 14 months have helped all of us realize that healthcare is everyday heroes, right? And I think it's shown the light in all the right ways. So thank you. Second point of thank you is for sharing your time with me and with your co-panelists here and with our audience. This has been a super rich discussion. I know my food for thought here is spinning, and I'm definitely smarter coming out of the session than when I came in. So thank you. I think we've covered all the questions that was submitted by the audience, and I'll turn it back to the Texas Medical Center team to wrap up. I know I'm getting the hook here, but Ashley and Emily, I'll turn it back over to you. But as having had the privilege to kind of guide and facilitate the discussion, I really appreciate the panelists. Really, very, very rich insights. Appreciative of the candor and just the transparency. So thank you.
Wonderful. Well, thank you. And I want to echo Adnan's thank you. Thank you to you to hosting and sort of being our moderator during this, and to all of the panelists. We found this to be so helpful just to hear what people are currently doing, how things have changed over this past year, and where we're heading, how we learned these lessons. So it's great to hear from people. We really appreciate your time, and to everybody attending, thank you very much. Just a quick announcement. Our next session is going to be the future of AI in healthcare. And so that's going to be a session for July. So we'll make sure to send that information out to everybody who participated today. But again, want to thank all of our panelists and Adnan for being the moderator, and also thank Autumn, Christina, and Maya, who we work with in Denmark and UK, that are sort of our counterparts that help us find our wonderful panelists and really help make the connection. We're so excited to see these BioBridges continue to grow and look for further partnerships that we can do together. So with that, I will close it for the day, but thank you, everyone. We appreciate all of your time.
Thank you.
Thank you, everyone.